Hey guys, and welcome back. It's just Floyd today because Ryan and I haven't been able to synchronize our schedules as of late. We've been super busy, but we're going to rendezvous back together again soon. Enough small talk. Let's get started. Today, we're discussing vasodilatory shock states, specifically sepsis, but in my mind, many of the physiology of vasodilatory shock is the same, but most of the literature that I'm going to be referencing pertains to sepsis. Your EMS service may or may not be focusing on sepsis care. Some of you may have started a long time ago. There was a big push for it years ago, and some early adopters may have picked it up and ran with it. And in doing so, you likely extrapolated some aspects of your protocols from the hospital's guidelines, which I think is fine most of the time. But things change, and we adopt stuff only to find out that what we're doing is harmful. Most of the sepsis guidelines call for administration of large amounts of fluid, and then the administration of a vasopressor, but only after this arbitrary amount of fluids are given. This is reckless behavior, and while sepsis guidelines have decreased mortality, mostly by just making it something that we should look out for, and by increasing awareness, we're now finding that there are some things we've been doing that we shouldn't be, and if we stop doing those things, then we can decrease morbidity and mortality even more. Now, before we adopted any sort of guidelines, conventional wisdom when it comes to giving fluids and vasopressors always said you should prime the pump. And if you're sitting there thinking, yeah, that's right, that's what I tell people, then just keep listening. There's been a movement to standardize treatment of patients in shock and to standardize treatment of patients in general, but especially septic shock. While standardization can be a good thing, I'm reminded of a quote from Sir William Osler. He says that variability is the law of life, and as no two faces are the same, so no two bodies are alike, and no two individuals react alike and behave alike under the abnormal conditions which we know as disease. Now we're going to be covering the concept of fluid responsiveness, which basically means that when you give fluid to a patient, the patient responds with a corresponding increase in their cardiac output. Prime the pump is a flawed paradigm based on flawed reasoning and probably a poor understanding of venous return as it relates to cardiac output. When I hear people say this, I don't think they really understand how, quote, balanced fluid distributes through the body, and that fluids are actually not the best and not the only way that we can prime the pump. I myself have always sort of struggled on this topic, and I always wondered, how much fluid do I give? Or did I give too much? Or am I giving enough? And how much should I give before I start a presser? To be honest, right now I'm only just a little less confused than I was before, and my goal isn't to provide some sort of earth-shattering insight or critical care exclamation or any sort of unequivocal recommendation. Many claim that they have the answer or the holy grail of evaluating fluid responsiveness, or that they have the holy grail of exactly how much fluid we should give before we start a presser, but they don't. My goal is to explain this so that people like me, your average frontline ground paramedic, can confidently, safely, and rationally give just the right amount of fluids and vasopressor support. To really understand what we're discussing, you have to know a little bit about fluidology, kind of like physiology, but fluidology. And you have to know how the fluids that we give distribute through the body. They don't just remain in the vascular space. Fluid resuscitation is not a benign intervention. Giving large amounts or large volumes of fluid is associated with increased morbidity and mortality. But we give these volumes, or at least I think that we give these large volumes of fluid because it's easy and it's something that we're accustomed to, and because of a lot of anecdote. We're taught that it's relatively benign to give someone fluid as long as their lungs are clear, but short of having ultrasound and having the expertise to utilize it, then the clinical assessment of the lungs will fail you unless the patient is presenting with frank pulmonary edema that you can hear on auscultation. So exactly what happens when we give that fluid bolus to the patient? A lot of it depends on which type of fluid that you give. The most used fluid in resuscitation is 0.9% saline. And that's not a great fluid to use for resuscitation. And balanced fluids in general are not the best things. But unfortunately, we don't have a lot of options. In healthy adults, only 15% of your fluid bolus remains in the vascular space. And there are some sepsis models where almost 100% of the fluid bolus filters out into the interstitial space. So these solutions that we give mostly replenish the interstitial space, not the intravascular space, which is needed to maintain venous return and cardiac output. This is great for the patient who is actually dehydrated, and most people are just a little dehydrated, but in the vast majority of patients, we give huge amounts of fluid that treat the dehydration and then some. Marino's ICU book says that infusion of 1 liter of 9% saline adds 275 mLs to the plasma volume and about 825 mLs to the interstitial volume. However, the total increase in the extracellular volume after giving these fluids is slightly greater than the infused volume. And this is the result of a fluid shift from the intracellular to extracellular space because saline is slightly hypertonic in relation to extracellular fluid. And out of all of the patients that you've given fluid to, only about 50% of patients are going to respond to that fluid bolus in terms of an increase in cardiac output. So there are times when the right ventricle cannot accommodate the fluid bolus. And there are times when the left ventricle can't accommodate the fluid bolus. If the left ventricle can't handle it, then you get pulmonary edema or fluid buildup in the lungs. If the right ventricle can't handle it, then all you do is get an engorged venous system. But in at least half of the patients that you're giving this fluid to, they won't respond with a corresponding cardiac output. Now, traditionally, sepsis and other distributive shock states were considered a problem primarily with increased vascular permeability, and secondly, with a loss in vasomotor tone. But now the reverse is considered to be true. Most now appreciate that sepsis is more of a problem with vascular tone and less of a problem with vascular permeability. However, excessive fluid administration can damage what's called the glycocalyx, and that surrounds the cell membrane and is responsible for regulating permeability of the endothelial lining. Damage to the glycocalyx allows intravascular fluid to shift into the interstitial space. So it's possible that vascular permeability has less to do with the disease state itself and more to do with iatrogenic harm that we are causing by giving large amounts of fluid. Last but not least, saline is an acidotic fluid, and giving large amounts of fluid can contribute to metabolic acidosis. Now that we've covered a bit of fluidology, we have to understand venous return and what happens to the venous side of the vascular system in vasodilatory shock. The venous side of the circulatory system is a major player in the game of shock. We see and manage many different forms of shock, and of course you should be aware of the physiology and mechanisms at play in all of them. But most are to some degree caused by dysfunction in the venous vasculature, which in turn causes decreased venous return. And hopefully by understanding this, it will make more sense why early vasopressor therapy has been shown to decrease mortality. The venous side of the vascular system is essentially a reservoir for the return of blood to the heart. The majority of the body's blood volume is contained within the veins. The veins are also very compliant compared to the arterial side, and because of this, you can have huge changes in the blood volume of the venous side, which can essentially pull within the veins without a huge change in the venous pressure. Now, the ability of the venous side to accommodate all this volume is an important adaptation because when you encounter a stressful situation, it allows you to turn all this potential volume, which is referred to as unstressed volume, into stressed volume. It can squeeze those vessels and increase venous return to the heart. Occasionally, many of the pathologic conditions that we treat prohibit the body from turning the unstressed volume into stress volume, which, as stated previously, is now considered one of the predominant factors in some circulatory shock conditions. The reason for shock isn't as much a problem with the leaky vessels as once thought. It's just fluid congesting in this unstressed venous system. Hopefully by now you're convinced that too much fluid can be a bad thing, and that the amount you have considered to be too much or even just enough is probably a much less amount. There's a huge paradigm shift to give less fluids. A lot of fluids is bad for cardiogenic shock patients. It's bad for trauma patients. It's bad for burn patients. We, as EMS providers, give too much fluid. What we want to know is the patient going to respond, or are they not going to respond? If we increase the venous return, will they have an increase in cardiac output? It's imperative to understand that not every patient will respond to fluids. So if you knew that a patient's cardiac output would not increase after giving a fluid bolus, would there be any reason in giving it in the first place? Absolutely not. But we're told to prime the pump. So what are the reasons that a patient would not respond to fluid? This all goes back to the Frank-Starling curve and Starling's law of the heart, which is the ability of the heart to change its force of contraction and therefore stroke volume in response to changes in venous return. As you change or increase preload, you would expect the ventricle to distend or stretch, which theoretically should increase the strength of ventricular contraction. However, practically no two patients will be at the exact same section on the curve, and the curve can shift. Some patients may already be at what I refer to as their maximal myocardial stretch. Some patients still might have some stretch left in their sarcomeres, which means that they should theoretically respond to a fluid bolus. But we tend to treat every single patient as if they have infinite stretch in their ventricles. So what do? We give a 250 to 500 bolus, and if that doesn't work, we just keep doing the same thing over and over, expecting different results, not appreciating that the patient's not responding and that there are unintended consequences of giving these boluses that over time can become 20 liters and the patient begins to blow up like the Michelin Man. I see so many paramedics who just keep pouring the fluid to the patient when it's clearly not doing anything. But is some fluid okay? And if so, how much is too much? When exactly should we switch from giving fluid to starting pressor therapy? Well, too much is slightly more than just enough, and it's certainly less than you think is too much. We're transitioning from an empiric administration of therapies, such as prime the pump or GCS less than 8 intubate, to a less is more approach. And we're realizing that we're harming patients by doing things with no real evidence or sound physiological reasoning. Dr. Paul Merrick says that we wanted to give just the right amount of fluid, but it can be difficult to know what just the right amount is, especially for pre-hospital providers. There are various proposed ways of determining whether a patient will respond to fluid or not, and many of the holy grails that were once espoused have either been flawed or require expensive equipment and particular expertise on how to use that equipment, and most of them require the patient to be mechanically ventilated. There are tons of ways of determining fluid responsiveness, and everyone says that they have the answer, but I'm not really sure anyone does. And to be honest, this is not an area that I'm an expert in. We don't currently have ultrasound in my system, which I think might be a reasonable tool to use to determine fluid responsiveness when used by an expert, but it's still not practical for many departments in my area. To be clear, I don't think something such as 500 to a liter of fluids is going to cause any significant harm unless the patient has renal failure or already has severe cardiac failure. I don't think it's going to be very deleterious to try a 250 to 500 cc bolus, but we need to appreciate that any fluid we give will become excessive if we consider the cumulative effect of our bolus plus those of the referring or receiving facilities that we transport to or from. So exactly how do we measure for fluid responsiveness? To do this, you've got to use a dynamic approach. Things like blood pressure, CVP, wedge pressures, they're all static measurements. Dynamic measures are more important because of the Frank-Starling curve. As you increase preload, you would expect the ventricle to distend or stretch, which, as we stated, should increase the strength of ventricular contraction. Blood pressure is a static measure, so you need a dynamic approach. We know, based on the Frank-Starling curve, that only some patients will respond to fluid administration. And how do we identify those patients? Do we want to give a fluid challenge in a patient who potentially won't respond to fluid, since fluid can be deleterious? And in most cases, you have to give fluid to actually know. But there are other ways that have been proposed. There's some promising research on using end-tidal CO2 to help predict fluid responsiveness. It's pretty intuitive considering that end-tidal CO2 is a reflection of cardiac output. And if the bolus that you give improves cardiac output, then you'd expect an increase in end-tidal CO2 because we're increasing blood flow to the lungs. Now, the test we're about to talk about, I don't think is something that we should start doing tomorrow, but I really think it's cool, and it's something that might be of value in the future. This test is known as the passive leg raise test. To perform the passive leg raise test, you place the patient supine and you raise the patient's legs about 45 degrees. What this does is relocates the patient's own blood into central circulation. For a patient to be responsive, the end-tidal CO2 should increase about 5%, and this should happen within about a minute. A few studies evaluating this procedure demonstrate fairly good sensitivity and specificity, even in a spontaneously breathing patient. Now, I'm still not sure there's enough compelling evidence to fully adopt this. I think it's important to note that any changes in cardiac output when we perform this test are only going to be temporary. That's why we don't routinely elevate patients' legs in shock, because we're only going to see a temporary improvement. To be clear, one thing I'm not espousing is complete abandonment of fluid administration altogether. While some are recommending this approach, we definitely need to accept that the prime the pump paradigm has failed and appreciate that early vasopressor therapy improves survival from sepsis, and I think it's a fair assumption to say that improving perfusion to the tissues in any shock state is a good thing. So what does this mean for the frontline provider with 4 wheels on the ground? I think sometimes you just have to rely on clinical gestalt. Now, the goal is a MAP of 65 or greater. But if the patient has an altered mental status or the extremities and the knees are cool to the touch, you have little to lose by starting a pressor early at a low dose, and you have a lot to gain because that means that you can relocate, you can turn that unstressed volume into stressed volume, and you don't have to give as much fluid. Conversely, you have a lot to lose by empiric administration of fluid therapy, and there's a 50-50 chance that the patient doesn't need it anyway or won't respond to it. Is it harmful to give fluid in small aliquots to see if the patient responds? Probably okay, but the traditional methods of determining if the patient's going to respond, i.e. your clinical assessment, is usually inadequate. But there's no reason that you can't give a small fluid challenge and start pressors if you don't see an appreciable response from the fluids. I recommend being conservative with both and giving small fluid challenges and starting low-dose pressors. Now, there's basically 2 stages of septic shock. One is the warm stage, where the patient's heart is hyperdynamic. Then there's the late stage, or cold shock, where the cardiac output is decreased because of the sepsis-induced cardiac dysfunction. And chances are that if we're seeing a septic patient in frank shock, that they have some degree of cardiac dysfunction. They're going to need vasopressor support, and they're also going to need some inotropy. So when exactly do you start pressors? You don't have to give liter upon liter of fluid. Chances are they're not going to respond to fluids anyway, so just give fluid in small aliquots and give pressors to maintain a MAP of greater than 65. Just think back to all those times you considered starting a pressor, but you wouldn't commit because you kept thinking, or you kept hearing that voice in the back of your head, prime the pump, or just one more bolus and we'll be at the hospital. Those are times when you probably should have just started the pressor. Or how about all the interfacility transfers you've had where the patient received 4 to 5 liters of fluid and they still had a MAP of less than 65 and they had fluids going at 150, 200 mLs an hour, and you just kept giving a fluid bolus even though they've already given 4 to 5 liters and the patient's still in frank shock. That is a time when you probably should have started a pressor. Now let's say that you've given your marginal fluid bolus and you determine that the patient didn't respond and you want to hang a pressor. What is the ideal pressor? What is the pressor of choice? Well, I'll tell you what it is not. It is not dopamine. I'm not going to get into dopamine much in this podcast, but I just want to tell you that it is dead. Now let's imagine that you had a patient with frank septic shock. You're working in a rural EMS system and you decide to transport the patient an hour away to an academic center. You quickly start an IV because the patient had a weak radial pulse and you administer 1 liter of lactated ringers in 250 to 500 ml aliquots, but the MAP is still less than 65. You decide that the patient probably isn't responding to fluid administration, and if you don't start a pressor now and improve the MAP, the ED is likely to give a few more liters of normal saline. But you only carry dopamine. And you've heard from a speaker at your state EMS conference that dopamine is bad, and your service refuses to get norepi. Should you just hang the dopamine because, well, it's better than nothing? The short answer is unequivocally no. Every single ambulance and every emergency room has what I think is a perfectly reasonable vasopressor for use in nearly all forms of shock, and that is epinephrine. Sure, you don't have norepi, which is currently considered the first-line vasopressor in most forms of shock, but when it comes to vasodilatory shock, epinephrine is considered a second line, and it works perfectly well if the patient is in cold shock when they have some cardiac dysfunction. I think you'd be hard-pressed to find any evidence that epinephrine is inferior to norepinephrine when it comes to patient mortality. You're not losing a whole lot by not having norepi if you know how to properly mix and administer epinephrine. We don't have enough time to discuss the effects of various pressors, but I also think we don't spend enough time in paramedic school to be competent in this area. Also, there are easy ways of giving epinephrine without a pump. If you give any concentrated pressor, you should probably be using a pump. And yes, if you give a vasopressor in any concentration, you should probably be using a pump. But that's just not the current reality in many EMS systems. So there's recently been a dopamine shortage in my area. My state EMS office released a memo, quote, approving an epinephrine drip and push-dose epinephrine as an alternative to dopamine. But they only approved this for use during the shortage. However, they stated in a memo that dopamine should no longer be a first-line vasopressor, or they use some similar language. But they won't write that into the full protocol, and they expect us to go back to dopamine when the shortage runs out. And I just wanted to ask anyone listening who knows the reason for this, let me know. Epinephrine is a powerful vasopressor, which will turn the unstressed volume into stress volume, improve venous return, and prime the pump. If the patient is septic, they quite possibly have some cardiac dysfunction. And if they didn't, then they're going to after the patient gets 5 liters of saline. After you improve the preload and increase the afterload, there's a good chance that the patient did have some cardiac dysfunction, but didn't have much to pump against, so that cardiac dysfunction didn't manifest itself before you added a pressor. But that's fine because epinephrine is also an inotropic agent and will augment cardiac output. I'm going to have a few studies in the references comparing epinephrine to norepinephrine in sepsis and epinephrine to norepinephrine plus dobutamine in cardiogenic shock. And if you think that it's a bad choice to use epinephrine, look at those studies. But now that you're hopefully a little less afraid of starting a pressor, epinephrine is not premixed. So how do you mix it? Well, it's very easy, and I'm going to have a graphic on the website that you can save to your phone, print, or whatever you want to do with it. If you've never heard of push-dose epinephrine, then it's probably not what you're thinking. It is not giving small push doses of cardiac 1 to 10,000 epi. It's diluting 1 to 10,000 down to make 1 to 100,000. To conceptualize this a bit more, in your cardiac amp of epi, there's 1 milligram in 10 cc's. To break it down even further, there's 1,000 micrograms in 10 cc's of cardiac epi. All you have to do is take 9 cc's of saline in a 10 cc syringe and add 1 cc, which is 100 mics, of epi in with the 9 cc's of saline and shake it up. Then your concentration is 10 mics of epi per ml. You can administer 1 to 2 mLs PRN, which is 10 to 20 mics. This is a quick and easy method for giving epinephrine to a patient who's crashing in front of you or when used as a bridge to setting up an epi drip. And it is very precise, and it's much more accurate than hanging an epi or norepi drip under gravity. But you decide that you have time to set up an epi drip. Now again, I don't strongly advocate for running a vasopressor without a pump, but I think if you have to do it, this is the way to do it. And I'm a huge fan of keeping things simple. All you need is 1 milligram of epi. It doesn't matter what concentration. Put that milligram in a liter bag of saline. Now the concentration is 1 mic for every ml because you put 1,000 mics of epi in 1,000 milliliters. Using a 10 drop set, 10 drops is 1 ml, so 10 drops is 1 mic. Start off about 20 drops a minute, which is 2 mics. Titrate up from there. The only issue with this method is that it's a very dilute concentration, meaning that you need to give a lot of fluid if you need to give higher doses. But luckily, if you start a low-dose vasopressor, then you're also giving some fluid, so you're going to improve venous return by turning the unstressed volume into stressed volume, and also by the little bit of fluids that you're giving. So hopefully you won't have to give a whole lot. Here's a question that I get by many people. If you're transporting a patient in your facility and they're on a norepi drip, but the patient still has poor perfusion, can you add on epi? Meaning, can you give 2 vasopressors at once? The answer is yes. And in fact, that is what some of the guidelines say to do. Patients don't respond to vasopressors the same way. If the patient is maxed out on norepi and you add on epi, they may respond better to epi, and then you can titrate the norepi down or eliminate it completely. You can't accurately predict how a patient will respond to vasopressors. Some patients will respond better to epi than norepi. I personally have seen a huge shift in how we manage patients within the past 7 years. It used to be leave a fed, leave them dead. And now dopamine is dead and norepi is the first line for about everything. The key takeaways are as follows. Give less fluids. Most of the novel methods of determining if a patient will respond to a fluid bolus are not available to pre-hospital providers. Don't completely abandon fluid administration, but give it judiciously. Give pressors as early as possible to maintain a MAP greater than 65 when it appears that the patient is not showing any improvement after small aliquots of fluid. Septic shock is primarily a problem with vasodilation, and capillary leak in sepsis has been overstated and is possibly caused by excessive administration of fluids. Epinephrine is a perfectly acceptable vasopressor for most shock states and is certainly better than dopamine. As always, thanks for taking the time to listen to me speak. We hope that if you have any questions or feedback, that you'll leave them in your social media of choice. And if you have any recommendations for a future podcast, we would love to hear those too. This is Floyd with Curbside to Bedside.